So mainly in this session, we will be discussing about Lorlatinib in the management of ALK and NSCLC. And mainly we'll be talking about a CROWN trial, which led to FDA approval for this agent in first line setting. Next slide, please. Next slide, please. So I think this is just the repetition. We all know this, but we know that why it is important to discuss lung cancer. The burden is increasing. We know it's a common cancer of as per incidence as well as mortality. And we know that we have come so far from a histological based diagnosis to a molecular diagnosis. And as we have discussed the use of NGS, and we have getting more and more mutations, and thus it has become more of a personalized medicine rather than a histologically based treatment now for lung cancer. Next, please. This is just to show that lung cancer is not static. The incidence is increasing, and it is predicted that by 2040, the number of patients with lung cancer will almost double of what it is now, and so is the mortality. So more and more effective therapies and more understanding of these rare mutations and newer drugs will be needed for practicing medical oncologists more than before. Next slide, please. Next slide, please. Next slide, please. So we'll start with a brief discussion on ALK mutation. So ALK is one ALK gene rearranged lung adenocarcinomas are variable, and the incidence varies based on the demography we are studying and the type of population we are studying. So this is one study which is from Dr. Navee's group from PGI Chandigarh, where they studied the incidence of mutation in their population, and it was found to be 8% from North India. The percentage of this mutation varies from somewhere between 2%. We had a TMH movement where we studied the incidence of this mutation, and the rate was almost around 6 to 8% in our subset also. Next slide, please. Next slide. Yeah. So as we know, as with EGFR, we know that there is some morphological characteristics which are more seen in this mutation, but they are not pathognomic of these mutations, and we need to do testing for this mutation before starting treatment. So what is more common is this? These are mainly adenocarcinomas. Rarely, less than 1%, we have few patients which are squamous morphology and ALK. Therefore, now NCCN also recommends doing EGFR ALK mutation in squamous cell lung carcinoma also, although the percentage is rare, less than 1 to 2%. They are typically, but not always. So that has to be seen, so that we should not restrict doing these mutations in patients who are smokers. So they are more common in non-smokers, but they are found in a small subset of patients who are smokers also. They occur in a younger patient as seen with EGFR. And there are different partners for ALK mutation, with the most common being EML4. Although we used to think that EGFR and ALK are mutually exclusive, but there are case reports. We have case reports from Tata also, where we have found that there are few patients who have a mutation of EGFR as well as ALK, and the management of these is beyond the scope of our discussion at present. Next slide, please. So just to understand that what is this EML4 ALK fusion. So it's a type of inversion rearrangement where the part of chromosome 2 where the ALK gene is present get broken and get fused with EML4 gene, resulting in a EML4 ALK fusion protein, which leads to a constitutionally active tyrosine kinase, which leads to uncontrolled cell growth. Next slide, please. So before going to this, I would just like to say that various methodologies for testing ALK there are three methodologies which are recommended by USFDA. One is NGS, second is IHC, and third is FISH. And I would like to make a point here. So in this ALK mutation, we know that the FISH and the IHC has concordance, and so a simple test like IHC is good enough, and we don't need to repeat a FISH or NGS to get a ALK mutation. But as tissue is the issue, so we normally get NGS as the number of mutations are increasing, and we need to save the tissue. But IHC is concordant with a FISH in almost 97 to 98% of population. So if we look at the timeline of ALK inhibitor development, we can see that the discovery of this mutation or translocation occurred in 2007, and the first line therapy, which is Crizotinib, came after 5 years. And after that, there is a lot of development which have occurred, and we have now second generation as well as third generation agents which are there. And now in 2021, Lorlatinib, which is third generation ALK inhibitor, has been approved in first line also. So this talk we will primarily discussing about the CROWN trial, which led to the FDA approval of Lorlatinib first line. Can we move to next slide, please? So what are the current treatment options in ALK positive patients, and why is there unmet need despite all these armamentarium agents which we have there? So as we can see that ALK positive patients are generally young and they are light smoker. So they have a lot of life which is pending, and giving a good quality of life and increasing survival become important. ALK patient have a predispensity to have CNS metastasis, which is seen in almost 20 to 40% of untreated ALK patients. And so it's a significant challenge because a lot of agents have a restricted entry into brain. As we know, as with EGFR, there are a lot of resistance mechanisms which are present when patient progress on first-line therapy, and these leads to resistance to present drugs. Next slide, please. So a bit about Lorlatinib. So Lorlatinib is a selective ATP competitive potent third generation ALK TKI. So what is important to know, which differentiate it from other, is it has an excellent brain penetration, almost 75%. Secondly, it is active in resistant clones like G1202R, where other ALK inhibitors, even the third generation like Brigatinib, are not effective. So this is where it is different from other ALK inhibitors, and there is a place for this agent in the armamentarium of ALK inhibitors as we move forward. Next slide, please. Next slide, please. Next slide. Next slide. We have already talked about. Yeah. Next slide. So now let's talk about the CROWN trial, which led to the approval of Lorlatinib in first line. This was a randomized multi-center study. Next slide, please. So this is a study schema. So this was a randomized multi-center study which enrolled patients with frontline ALK positive NSCLC. It included patients with stage 3B, mainly metastatic patient with ALK positive non-small cell lung cancer, frontline patient with ECOG up to 2. They included patients with asymptomatic, treated or untreated CNS mets, and they should have at least a site of measurable extracranial lesion. They were randomized 1:1 to either Lorlatinib or Crizotinib in standard dose. There was a pre-stratified subgroup by presence of brain mets as well as ethnicity, which they wanted to study. And the primary endpoint of the study was progression-free survival by a blinded independent central review. So there are two things which I want to highlight in the study schema. So they have included patients even with PS2, which is rarely seen in clinical trials now, and which is more in line with the clinical type of patient which we see in our practice. And they have included patients with CNS mets. Secondly, a lot of trials now have PFS, which is by investigator. which lead to some biases, but they have taken PFS by independent central review as their primary endpoint. And they have secondary endpoints of PFS, intercranial response rate, overall survival, safety, as well as quality of life, which is important nowadays when we are talking about these type of agents. Next, one more point which I want to highlight is there was no crossover which was allowed in this trial. So they enrolled 296 patients, which was through 23 countries, and they were equally divided between the two arms. They imaged these patients for restaging every 2 weeks with abdominal CTs as well as brain imaging. So what we can see at the interim data cut, which was at 20th March 2020, there was 103 patients in Lorlatinib group and 31 patients in the Crizotinib group who already was on treatment, so that they were not progressed. And the median duration of follow-up for the Lorlatinib arm was 18.3 months and 14.8 months was for the Crizotinib arm. Next slide, please. Next slide. So the baseline characteristics were fairly matched between the two groups. Previous slide. But there are a few things which I'll like to highlight. So the median age of the study group was in between 56 to 60, which is what we clinically see in our patient also, that the ALK quality patient are falling within this age group. They divided the patient into white, Asian, and other ethnicities, and we could see half of the patients were white and half were Asian. Although they mentioned that they included ECOG PS2, what was disheartening to see that there were only 2 patients in the Lorlatinib group and 6 in the Crizotinib, which was in PS2 group. I would have liked it to be more realistic and more patients in a poor PS, which is usually the case what we see in clinics. If we can see, most of the patient were a never smoker and our previous smoker. That is what the subset of ALK quality patients are. And almost 1/4 of the patient in both the groups have brain metastasis at presentation. Can we go to the next slide, please? So if we look at the primary endpoint, which is the PFS, this is nothing to explain. The curves explain themselves. There is an early separation and a progressive separation of the two curves with a beautiful separation of the two curves between each other. And we can see there is almost a doubling from 38% to 39% to 78% at 12 months of the PFS, which is very unlikely to see in trials nowadays. Which are rare in first-line trials nowadays. So if we can see the events which were there were only 41 in the Lorlatinib arm and 86 events in the Crizotinib arm, with a median PFS of 9.3 months in the Crizotinib arm, which we already know from the historical data, and the median PFS is not reached in the Lorlatinib arm, and the hazard ratio is a healthy 0.28, leading to a 72% relative improvement in PFS. Next slide, please. The secondary endpoint of PFS by investigator also show the same results. There's a 80% PFS at 1 year in the Lorlatinib arm versus 35%, which is similar to what is seen by independent center review. Next slide, please. So if we look at the forest plot and try to understand what all subset of patient benefit with this therapy, we can see it's rare to see this type of forest plot nowadays, with all the subgroups having a significant benefit with the hazard ratio, which is in the range of 0.2 to 0.3, showing that Lorlatinib benefits patient across subgroups, whether they have brain mets or not, whether they are Asians or non-Asians, despite of PS, the sex, the age, and the smoking status. Next slide, please. So if we look at the response rate also, what is good to see that there are 4 patients even in the stage 4 group who have complete response, and 73% patients have partial response as compared to 58% in the Crizotinib arm. So this is very good to see, because with the decrease in burden of disease, there is a definitive increase in the quality of life of the patient, and it gives us confidence in the therapy. And if we see, the median time to response is also 1.8 months, which is similar with quizartinib. And the median duration of response is 11 months with quizartinib, and it is still not reached in the lorlatinib arm. Could we go to next slide, please? So if we look at the intracranial response rates in this patient, which is, we know that lorlatinib has a good CNS penetration, and we expect it to have good response rates in CNS, and it has not disappointed us. So if we can see, out of the 38 patients who have measurable brain metastasis at baseline, 66% have responded, as compared to only 20% in quizartinib group. And if we look at the complete response in brain, which is rare to see, almost 61% patients out of 38 have a complete response in brain as compared to 15, which is very good to see. If we look at the patient with measurable brain mets also, we can see that 71% patient, that is 12 out of 17, have complete response in brain. So this help us in avoiding therapies like WBRT or radiation therapy, and we can have good response with these therapies, so we can avoid multimodality therapies in these type of patients. Can we go to next slide, please? So this type of flat curve, I need not explain that thing, but if we look at the intracranial time to progression, we can see almost none of the patient on lorlatinib had progressed within a median follow-up of 33 months. So if we see, only 5 patients out of 149 in lorlatinib had intracranial progression, as compared to 45 in the quizartinib arm, and the hazard ratio 0.07, which is very, very good. Can we go to next slide, please? Although overall survival was a secondary endpoint, and the data was not mature enough to comment on overall survival, still the hazard ratio was 0.72, but the confidence interval was crossing unity. But as I said, it's not a primary endpoint, and the data was not mature to study OS, so we could not comment on overall survival. Could we go to next slide, please? So this is the most important slide which I want to look. When we look at the when we have to look at the efficacy, we have also to balance it with the safety of the agent, and that is important to know. So if we see, almost every patient in either the quizartinib or lorlatinib group had any grade of side effects, with almost 72% of patients in lorlatinib group having grade 3 to 4 side effect, as compared to 56% in quizartinib arm. And serious adverse effects were comparable between the two groups, being almost 30% in both. There were 7 events which were fatal in both the groups. And if we look at the patient who have to discontinue treatment because of side effects, this was low. This was not much. This was 7% in the lorlatinib group, which was comparable with quizartinib. And the temporary dose interruption was also comparable in both the groups, saying that although it has more grade 3 and grade 4 side effects, these are mainly laboratory, as you will see in the next slide. And patients' outcomes and the patient discontinuation.
So I request you to conclude your session.
Sure.
In 2 minutes.
Sure. So if we see as the side effect profile, we can see that mainly the side effects which are worrisome in these patients are hypercalcemia, hypertriglyceridemia, which are a different side effect which are seen with lorlatinib, which is not seen in other type of ALK inhibitors. Other type of side effects are not worrisome with this type of patient. Can we go to next slide?
Sorry to interrupt. I think so we can take another 5 minutes, so not an issue.
Okay. So if we look at the quality of life score, when we are looking at a newer therapy which is more effective, we should always look at the quality of life, whether they are not decreasing the quality of life of the patient. In this regard, we can see that if we see the global quality of life score, which are studied by EORTC C30, which is the most standardized score for QL, we can see that the quality of life deterioration was not seen as much with Lorlatinib as with Quizartinib. So there is a preservation of quality of life, and that is mainly because of potency of this agent leading to decrease in disease burden, so that the patient has a better quality of life. Can we go to next slide? So to conclude, Lorlatinib, as we saw, resulted in a significant longer progression-free survival, significantly higher overall and an intracranial response, and an improved global QOL compared to Quizartinib in the first-line treatment of ALK-positive non-small cell lung cancer. If we have to see, the intracranial response rate were 82% in patients with measurable brain mets, with a complete response rate of 71%, which is very, very impressive, and a significantly longer time to intracranial progression. The safety profile of Lorlatinib is same as what we know from the phase 2 studies, which have led to approval in second-line studies. And the grade 3-4 adverse effects are mostly laboratory, and they can be managed with some temporary discontinuation or some decrease in dose of the therapy without affecting the efficacy of this drug. So these results support and are approved for the use of Lorlatinib for first-line therapy of patients with advanced ALK-positive non-small cell lung cancer. Next slide, please. Next slide, please. So one slide which I want to highlight is, because we see almost 3/4 of the patients on Lorlatinib had hyperlipidemia. So to know how to manage it become paramount when we are managing these type of patients. And it is not difficult, as we can see from a trial. Decreasing dose of the therapy to to a step down, or using fairly well tolerated agents lead to management of these hyperlipidemia. One or two points which I like to highlight is Lorlatinib is metabolized through CYP3/4A. So strong inducers or inhibitors of CYP3/4A should be avoided when using Lorlatinib. In this respect, atorvastatin, which is most commonly used statin, is metabolized through CYP3A4, and it should be avoided in this patient. And if we have to use statin, rosuvastatin or pravastatin should be the agent we are using. Similarly, when we are managing hypertriglyceridemia, which can occur because of this agent, genofibrate should be avoided because of CYP3/4A interaction, and other fibrates are the one which should be used. And if we look at an individual patient data from the study, most of the patient with a single step down reduction in dose from 100 to 75 were able to continue therapy with manageable lipid set points, and they did not need to discontinue treatment because of this side effects. Can we go to the next slide? Second side effect which are highlighted, which are seen more commonly with Lorlatinib as compared to other ALK inhibitors, is CNS effects, and which are obvious because of its higher CNS penetration. But what is important to see is only 24 patients, that is only around 15% of these patients, require dose modification for these CNS side effects, and most of these patients are able to tolerate this drug with this dose modification and doesn't lead to dose discontinuation in most of these patients. Next slide, please. Next slide, please. Thank you.